I am Dr. Kawita Bapat, Learn Simply. Today's topic is case-based discussion on the myomas affecting fertility. Myomas are very important subject because it's a day-to-day problem. Everyone sees myomas in their practices, and myoma for AUB, for all the classification of the FIGO and many more things are there. And they are very common disorder, as all of us know in our practices. 20 to 30% patients into the reproductive age, and the infertility it accounts almost 1.1 to 2.4%, and 140,000 hysterectomies and myomectomies are performed all over the world. So the clinical presentation sometimes is most of the time it's asymptomatic, and symptoms are related to location, size, number. Then there is always an excessive menstrual loss. Sometimes patient comes with anemia. Pain is also one of the symptoms. And infertility, especially when the location of the fibroid is submucous fibroids. And sometimes the pregnancy complications are also there with fibroids. So urinary changes like a pressure changes, urinary changes are there. So this discussion is basically, do myomas or can myomas affect fertility? It's definitely, when we talk about this, it's upon the location. If it's located into the cornal end and occluding the tubes, so the tubal occlusion can be there. If it is to the center of the uterus, it acts like a foreign body and it causes the infertility. Then sometimes it is to the cervical region. It may be there is an abnormal vascularity, not allowing to implantation of the embryos are there. So there is sometimes the endometrial inflammation that is also there. And the important, sometimes the fibroid size is so big, it changes the axis of the uterus and it's a deviation and everything. It's altered the contractility, sometimes more contractility. So these all are the factors which can affect the fertility if the myomas are there. Now, mechanism of reduced fertility associated fibroid. Why there is a reduced fertility with myomas? Number one, it hindered the gamete transportation because of the location, position, altered vascularization, so many things. Sometimes it's an obstruction of tubal ostia and endocervix, induced uterine contraction because some foreign body sort of thing, something is there. So more uterine contractions are there, and there can be implantation failure, like endometrial changes. There may be atrophy, there may be ulceration, there can be a focal hyperplasia and polyps. Vascular alteration, we all know about it. There can be a venous congestion, and there are so many factors that increase because of vascular alteration and the myomas. That's EGF, TGF, and IGF are more, and these are there. And complications, they may lead to this thing. They can, if the fibroid or the myoma is there, reduce infertility is not only the implantation, but can cause the spontaneous abortion, can cause the premature labor, can cause the ectopic pregnancy, can cause the IUGR, can cause the abruption of the placenta. It can lead to malpresentation. It can lead to dystocia because of the location, the head is there, and all those things. It can lead to postpartum hemorrhage. So the fibroid is not fun with the pregnancy. So these are the points. But now what are the observations of the reproductive dysfunction? About half of the infertile women with myomas become pregnant after myomectomy. So it's a good sign. 43% of women who presented in labor had at least 2 years of infertility. So these are the observation. Another observation is associated with high rate of overall pregnancy loss. If there is a fibroid, chances of pregnancy loss is 60%. Then myomectomy halves the risk of the spontaneous hemorrhages. This is another point. And surgery reduces the first and second trimester loss. So the diagnosis of the fibroids is very simple. We all know the location, position, site, myometrial, it crossing the myometrium, pedunculated. It can be cervical, it can be into the tubes, it can be into the endometrium, it can be a small polyp, it can be a cervical, so many things. But we can diagnose the fibroid with the help of fibroid. With the fibroid, again, we can diagnose the fibroid with the contrast sonography. It's very important just to push a fluid into it, and we can see a differentiated between the myoma inside and a polyp, and it's a connection with the uterine cavity, how it is. We can also diagnose by the HSG. This is another one thing. And diagnosis can be done with MRI. MRI has got a special role. MRI can give the labeling, the positioning, the pointing out where the fibroid, how much the fluid, this color flow is over there. We can see many more things with fibroid. Diagnosis with hysteroscopy is another. This has become a gold standard for the small polyps which are being missed by the sonography. We can diagnose it through hysteroscopy is another thing. Now, what are the prognostic factors? Basically, where about the location and everything. What are the? This is a multifactorial thing with the infertility. Age, if the patient is more than 35. It can be submucous or the intramural fibroid. And the number of fibroids are more than 5. It is one of the prognostic factors for the infertility. Then volume of the fibroid. Again, we should know by volume, by sonography, volume of the fibroid is more than 100 ml. It is definitely one of the prognostic factors for infertility. And the size of fibroids is more than 5 centimeters, more than 8 centimeters. We should worry and it should be treated. Another prognostic factors for the, if there is a repeated trimester pregnancy loss and even a small polyp inside the uterine cavity is a worrisome, and the location of the intramural myomas are another thing. If there is a presence of menorrhagia, this is another prognostic factor because see, if that fibroid is changing the action, alter vascularization, more bleeding, more anemia, the worst quality of life. This is also very important factor, and the duration of the infertility is more than 3 years. And if there is a fibroid and unexplained infertility, that's another prognostic factors. Now, then can fibroids impair the outcome of IVF? It's another subject to be thought about. Number one is a potential effect of the uterine contractility and the perfusion. So it is one of the reasons IVF being done. There is a fibroid, disturbed contractility, disturbed perfusion can lead to failed IVF. Second point, there's a change into the myometrial microvasculature, and so many factors are there as I've already been talked about. So they are there. Then the third point is the aberrant local expression of growth factors involved with the angiogenesis and as well as the regulatory process. Small factors can lead to the outcome of IVF. Now, submucous fibroids and fertility. Number one, submucous fibroids, 18% of all fibroid cases are the causal factor of infertility. Number two, low pregnancy and implantation rate in IVF present patients. Number three, pregnancy rates similar to the control of following surgery. Then intramural fibroids and fertility. There is an adverse effect when the cavity is distorted. Pregnancy rate decreases from 33% to 9%. If there is a fibroid intramurally, adverse effect when they have the cavities not distorted. Still there are chances. And third is the adverse effect when the size of the fibroid is more than 7 centimeters. Again, submucous fibroids and infertility, there is a no effect sometimes. That's another important thing. Now, what are the treatment options which we were talking about? Medical, we can give GnRH. We can give the selective estrogen receptor like SERMs. We can do the uterine artery embolization. Surgically, hysteroscopy, laparoscopy, and laparotomy, we can remove the fibroids. Medical therapy like a GnRH, we can give a 36 to 65% reduction into the size of fibroid, but primarily for the preoperative treatment. No significant effect on intraoperative blood loss, no effect of operating time, and degree of difficulty of the procedure and a postoperative morbidity. So it's a good and current management of fibroids prior ART does not include GnRH treatment. That's another important point. Then the SERM like raloxifene, low dose for 6 months, maximum effect when used with the GnRH. 70% reduction versus 40% reduction of GnRH alone, and then the uterine artery embolization. This is another thing. It's an important point. The size of fibroid reduces, there is a less bleeding, and there are the follicles, polyvinyl particles. They go through the uterine artery, they block it, and the effect is like that. But the fibroid shrinkage after uterine artery embolization is a 42% reduction in the volume. Number two, 70 to 86% becomes a symptomatic relief. A satisfaction rate is 91%. amenorrhea in 3% of women under 40, and should be avoided in women who desire pregnancy. So UAE is out of course for the pregnancy. Now, introduction of UAE, uterine artery embolism in clinical practice is a missed opportunity. If the patient desiring future pregnancy, the current statements for uterine fibroid is surgical. Laparoscopic myomectomy, certain. The size is less than 6 or 7 centimeter. Experienced surgeon, low risk of pelvic adhesions, high risk of recurrence risk of the uterine rupture during pregnancy. Hysteroscopic myomectomy, treatment of choice for the submucous fibroids, comparable pregnancy rates, risk of adhesions. Then laparotomic myomectomy, large and multiple fibroids, when entry into the cavity is expected, risk of bleeding and adhesions are there. Then the myomectomy techniques and the pregnancy rate. Hysteroscopy, pregnancy rate 16.7 to 76.9, is a big range, and mean pregnancy rate is 46.5. Laparoscopy 16.7 to 75, that's a 48. And the laparotomy 9.6 to 75 and 46.1. So almost myomectomy techniques, either by hysteroscopy, laparoscopy, or laparotomy, almost between the 46 to 45%. Then, does myomectomy has risk? If you are doing myomectomy on patients, we should consider, yes, increased uterine rupture risk after laparoscopy, intraoperative uterine repair, it depends upon increased energy use for the hemostasis and poor recovery. Then again, it forms the adhesion. Second look, laparoscopy is needed. Endometrial adhesions, yes. Now the golden questions and decisions, symptoms and complications, type, distance from the endometrium, distortion of the cavity, age, what is the ovarian reserve. So we are worried about other things also, and how it has been dealt. It is also important, and other factors of infertility. It's before marriage, after marriage, whatever it is. Now, there may be a circumstantial evidence, but in case of fibroids, causing infertility remains to be established. Absence of the evidence is not the evidence of absence. So, dangers of misinterpreting difference that do not reach significance. This is the main point. And thank you so much for the patient listening. That fibroid is always a common entity. Removal of the fibroids for the fertility patient is a gold standard though, but it is not the reason for we should evaluate all the associate factors also. And the location, site, size, thing, and expertise of the surgical skills are very, very important when we dealt with the cases of fibroids for fertility. Thank you so much for the patient listening. Thank you so much.